So here's a strange one to start with. What if I told you there's an antipsychotic on the market right now whose grip on a dopamine receptor is so strong, it actually outcompetes the brain's own dopamine for that receptor in a living dopamine-soaked human brain? That's not a theoretical binding assay number. That's cariprazine, and that receptor is D3. By the end of this video you'll understand exactly why that matters. For negative symptoms, for cognition, and for at least 2 exam traps hiding in this drug's licensing. What kind of drug is this chemically? Cariprazine sits in the same functional family as aripiprazole and brexpiprazole. All three are dopamine partial agonists, sometimes nicknamed dopamine stabilizers, but don't assume they're chemical cousins. Aripiprazole is built on a quinolinone backbone. Cariprazine is a completely different structure, a piperazine cyclohexylurea compound, same job, different tool. In the UK you'll see it as Regular, in the US as Vrela, same molecule, different brand, and spoiler for the next slide, different license. Here's where a lot of candidates trip up. What is cariprazine actually licensed for? And does that answer change depending which country you're in? In the UK as Regular, it has exactly one licensed indication, schizophrenia in adults. Full stop. But cross the Atlantic and as Vrela it's approved for 4 separate things: schizophrenia, bipolar mania, bipolar depression, and even as an add-on for major depressive disorder. That bipolar and depression evidence is real and well studied, it's just not on the UK label. Maudsley tends to position it as a second-line schizophrenia option, especially useful when negative symptoms are the dominant problem. Keep that licensing split in your head because it's exactly the kind of detail that gets tested. Why does one mechanism, D2-D3 partial agonism, produce completely different effects depending on where in the brain it's happening? That's the whole point of the 4-pathway model, and cariprazine is a brilliant drug to teach it with. In the mesolimbic pathway, where there's too much dopamine, cariprazine's partial agonism acts like a brake. It calms things down and reduces positive symptoms. But travel over to the mesocortical pathway, where dopamine is already low in schizophrenia, and that same partial agonist can actually top the system up a bit, which is part of why this drug has a reputation for negative symptoms and cognition. The nigrostriatal pathway is where the trouble starts. Even partial dopamine blockade there still tips the balance toward extrapyramidal symptoms, and cariprazine is known for a fairly high akathisia rate. And in the tuberoinfundibular pathway, because it's only a partial block, prolactin tends to stay fairly normal. Sometimes it even comes down if it was elevated to begin with. Let's slow right down and actually draw this out pathway by pathway, so it sticks. Starting in the midbrain, this is where dopamine cell bodies live, in the ventral tegmental area. Follow the first pathway up into the limbic system, that's mesolimbic, and that's your positive symptoms pathway. Now follow a second branch forward into the frontal cortex, mesocortical, your negative symptoms and cognition pathway. A third pathway drops down into the striatum, nigrostriatal, movement control. And the last one heads down to the pituitary gland at the base of the brain, tuberoinfundibular, prolactin control. Same drug, same receptor mechanism, 4 completely different jobs depending on which road the dopamine signal is traveling down. So which receptors actually define this drug clinically? 4 matter most. D3 first, and we've already covered why that's the standout. Affinity so high it functionally beats dopamine to the punch. D2 is also high affinity, but here's the key word: partial agonist, not full antagonist, which is what gives this whole drug class its stabilizer reputation rather than a blunt blockade. 5-HT1A is a partial agonist too, contributing to mood and anxiety benefits and helping offset some EPS risk. And 5-HT2A antagonism, only moderate here, weaker than something like risperidone, still plays its usual role of nudging the drug toward atypical behavior. Now the receptors that shape the side effect profile rather than the core antipsychotic action. 5-HT2B, cariprazine binds this one with high affinity as a pure antagonist, but honestly, what that does clinically for a patient isn't well pinned down yet, so don't invent a story here. Flag it as unclear and move on. Alpha-1B is interesting. Some data suggest antagonism here might blunt EPS, which sounds a bit contradictory given cariprazine's own akathisia problem. That tension is worth holding in your head rather than resolving too neatly. H1 and 5-HT2C affinity are both low, which is exactly why this drug doesn't carry much sedation or weight gain baggage. And muscarinic M1, basically nothing, which is why you won't see dry mouth, blurred vision or constipation as prominent features here. First PK question. How quickly does this drug actually get into the bloodstream after a dose? That's what Tmax tells you. It's simply the time it takes for the drug's concentration in the blood to hit its peak after you swallow it. For cariprazine, that's 3 to 6 hours, a fairly leisurely absorption, nothing dramatic. And unlike some antipsychotics where food timing genuinely matters, cariprazine doesn't show a clinically significant food effect, so patients can take it with or without a meal without worrying about altered absorption. Here's a question that's easy to skip over. Does cariprazine actually get into the brain, and how? This matters because a drug can look perfect on paper at the receptor level and still fail clinically if it can't cross the blood-brain barrier, that protective layer of tightly joined endothelial cells that keeps most circulating substances out of brain tissue. Cariprazine gets in the simple way. It's highly lipophilic, meaning fat-soluble, so it just diffuses straight across the barrier passively without needing a transporter to carry it through. We're not just assuming this. PET imaging studies, the kind that let you literally watch a radiolabeled drug occupy receptors in a living brain, have confirmed rapid dose-dependent uptake in both monkeys and humans. And here's a detail worth knowing. Some CNS drugs get pumped straight back out of the brain by a transporter called P-glycoprotein, which sits at the blood-brain barrier specifically to eject unwanted molecules. Next question. Once cariprazine is in the blood, how tightly does it stick to plasma proteins? And why would you care? Protein binding here is 91 to 97%, meaning almost all of the drug circulating in blood is bound to proteins like albumin rather than floating free and active. The practical implication is a displacement interaction risk. If you add another highly protein-bound drug, it can, in theory, knock cariprazine off its binding sites and briefly raise the free, active concentration. Now, half-life. This is the time it takes for the drug concentration to fall by half. And cariprazine has a genuinely unusual story here. The parent compound itself has a half-life of 2 to 4 days, but its major active metabolite DDCAR has a half-life of 1 to 3 weeks. That has two big implications. First, dosing frequency. You only need once daily dosing because the effective half-life is so long. Second, washout. If you need to stop this drug, active drug can linger in the system for weeks, which matters for switching antipsychotics or for pregnancy planning. And that leads straight into steady state, the point where drug intake and drug elimination balance out and blood levels plateau. As a rule of thumb, steady state takes about 4 to 5 half-lives to reach. With a half-life measured in weeks rather than hours, that means steady state for cariprazine can take well over a month. Clinically, that's crucial. You cannot fairly judge whether a dose is working or whether a side effect has settled after just a few days. So where does cariprazine actually go once the body starts breaking it down? Metabolism happens mostly through CYP3A4, with CYP2D6 playing only a minor supporting role. And this is a drug where the metabolites genuinely matter clinically. DCAR and DDCAR aren't inactive breakdown products destined for the bin. They're both pharmacologically active, and DDCAR in particular becomes the dominant circulating form over time, given how long it hangs around. In terms of getting rid of the drug, only about a fifth leaves via the kidneys. The majority exits through bile and feces. That's exactly why both hepatic and renal impairment matter here. Hepatic impairment slows the CYP3A4 metabolism that creates and clears the active metabolites, while renal impairment slows elimination of what does get filtered out. Severe impairment of either organ pushes this drug into not recommended territory. Let's nail down exactly which of these receptor actions are partial and which are full, because mixing that up is a classic way to lose easy marks. D2, D3 and 5-HT1A are all partial agonism, meaning cariprazine occupies the receptor and produces some activation, just less than dopamine or serotonin would, acting like a built-in ceiling. Everything else on this list, 5-HT2A, 5-HT2B, H1, alpha-1B, is full antagonism. Cariprazine simply blocks these outright with no activation at all. Don't assume every action in a dopamine stabilizer drug is partial agonism. It very specifically isn't. How do you actually start and titrate this drug in practice? You begin low, 1.5 mg once a day, and can step up to 3 mg as early as day 2 if it's tolerated. From there, further increases happen in 1.5 or 3 mg jumps, capped at 6 mg a day. And here's a genuinely useful clinical point. Going above 6 milligrams doesn't buy you more efficacy, just more side effects. So there's a real ceiling here, not just a regulatory one. Food timing isn't a concern, it can be taken with or without a meal, and the label doesn't mandate a particular time of day either, so that's a decision you can tailor to the individual patient. If you do need to stop it, a standard gradual taper is still sensible, but worth remembering. Because of that very long metabolite half-life we covered earlier, the effects of stopping can take weeks to fully wash out, not days. Now the part of dosing that actually needs a second slide to do justice to: enzyme interactions and organ impairment. Enzyme interactions matter a lot with this drug because of its CYP3A4 dependence. Strong inhibitors mean halving the dose under the US labeling, though it's worth knowing the Australian product information actually goes further and calls that combination contraindicated rather than just dose adjusted, a genuine cross-jurisdiction discrepancy worth flagging rather than smoothing over. Inducers, on the other hand, are avoided outright because nobody's entirely sure what happens to efficacy if you speed up clearance of both the parent drug and its long-lived active metabolites. And remember from the PK slides, both liver and kidney function need checking, because severe impairment of either organ takes this drug off the table, while mild to moderate impairment of either needs no dose change at all. Who should this drug never be given to, and who needs extra caution? The one absolute hard stop contraindication is hypersensitivity to the drug itself. Pregnancy and breastfeeding both call for caution rather than an outright ban. The main concern in late pregnancy is neonatal extrapyramidal or withdrawal symptoms after third trimester exposure, and it's simply unknown whether the drug gets into breast milk. Then there's a warning you'll see attached to every antipsychotic in this class: elderly patients with dementia-related psychosis carry an increased risk of death when treated with these drugs, and cariprazine is explicitly not approved for that use, full stop, regardless of how favorable its receptor profile looks on paper. And here's that licensing gap again showing up in a new place. In the US, cariprazine has pediatric approval down to age 10 for bipolar mania and age 13 for schizophrenia. In the UK, there's no pediatric license at all. What actually needs checking once someone's on this drug, and how does that change specifically for cariprazine? The backbone is the same as any antipsychotic: weight, glucose, lipids, prolactin ECG, blood pressure, liver and kidney function, and movement monitoring with something like the AIMS scale. Two things are worth flagging as cariprazine specific. First, prolactin tends to behave itself here. Because D2 blockade at the pituitary is only partial, prolactin often stays normal or can even fall from an already elevated baseline. Second, and this ties straight back to the pharmacokinetics, because steady state takes so long to reach, monitoring needs to continue for weeks after starting or adjusting the dose, since problems like akathisia can genuinely show up later than you'd expect with a faster-acting drug. Time for the side effect table. And this is where a fixed regulatory convention comes in that's worth knowing cold for any drug, not just this one. The BNF and MHRA use a standard frequency banding system. Very common is 1 in 10 or more, common is 1 in 100 to 1 in 10, uncommon is 1 in 1,000 to 1 in 100, and so on down to very rare. For cariprazine specifically, akathisia sits right up near or above that very common threshold. It's genuinely the signature adverse effect of this drug. Alongside broader extrapyramidal symptoms, tremor and restlessness, nausea and insomnia turn up commonly too. Cardiac effects like quart prolongation are uncommon rather than common, reassuring but still worth checking. So how does cariprazine actually stack up against the rest of the second-generation field? On almost every metabolic measure, it comes out looking good. Weight gain, lipid changes, glucose, prolactin, sedation, QTC, all sit on the low end, and one large comparative analysis across 18 antipsychotics put cariprazine among the handful with the best metabolic outcomes overall. But there's a clear trade-off, and it's the same one we flagged twice already: extrapyramidal symptoms and akathisia. That's genuinely one of the highest rates in the SGA class, and it's the single biggest reason patients stop taking it in trials. Sexual dysfunction is worth a mention only to say, the sources don't give a confirmed comparative figure here, so rather than guessing based on the low prolactin logic, it's better to say plainly that this one isn't firmly established. Two things this drug is emphatically not. First, is cariprazine somehow protected from neuroleptic malignant syndrome because of its gentler partial agonist profile? No. NMS has been reported with cariprazine just as with every other antipsychotic, and that's a point worth repeating for every single drug in this class. No matter how favorable it looks on paper, there's no such thing as an NMS-exempt antipsychotic. Second, what formulations simply don't exist for this drug? There's no depot injection, no orodispersible tablet, and no liquid. It's capsule or tablet only, which matters practically for adherence-challenged patients where a long-acting option might otherwise be considered. And stack that alongside the licensing gaps we've already covered. No UK license for bipolar or depression, no UK pediatric license, and no license anywhere for dementia-related psychosis. Last interaction question: what actually needs adjusting around this drug, and what can be left alone? Because CYP3A4 does the heavy lifting in metabolizing cariprazine, strong inhibitors of that enzyme are the main concern. The US labeling calls for halving the dose, though it's genuinely worth knowing that other regulators, like the Australian Product Information, go further and call that same combination contraindicated outright rather than just dose adjusted. That's not a contradiction to memorize away, it's a real difference between jurisdictions, and it's worth stating as such. Moderate inhibitors get a softer version of the same caution. Inducers sit in a different category entirely. Here the concern isn't toxicity, it's treatment failure, because nobody's fully mapped out what happens to efficacy when you speed up clearance of both cariprazine and its long-lived active metabolites, so the safer move is simply to avoid the combination. And CYP2D6. Since it's only a minor pathway here, inhibitors of that enzyme don't require any dose change at all. Quick fire round, 8 statements true or false, and these are exactly the kind of details that get mixed up under pressure. Is cariprazine licensed in the UK for bipolar depression? False, that's a US-only indication. Does it bind D3 more tightly than D2? True, is its D3 affinity actually higher than dopamine's own? True, genuinely unusual. Does it cause weight gain like olanzapine? False, quite the opposite. Are akathisia and EPS its most common problems, sometimes showing up late? True on both counts. Is CYP2D6 its main metabolic pathway? False. That's CYP3A4. Is it NMS exempt because of its gentler mechanism? False. Never assume that about any antipsychotic. And finally, does its long-acting metabolite mean steady state takes weeks to reach? True. So, back to where we started. Which antipsychotic binds a dopamine receptor more tightly than dopamine does? Now you know. Cariprazine, at D3. And now you know exactly why that matters for negative symptoms, why it comes with a real akathisia trade-off, and why the UK and US licenses genuinely don't match. If this helped, subscribe for the rest of the Pharmacology series, drop a comment with whatever tripped you up.